All right, I think we're all set here to start our fifth COVID webinar, Managing COVID-19 for the Otolaryngologists. Welcome back, everybody. We appreciate the interest and the return visits. So let's get started here. So as many of you know, this is the fifth one. We have posted the previous four to YouTube. There were links in the invite, and so you could watch them at your leisure. We will, of course, send this one out afterwards as well. Tonight's an action-packed agenda. Joining me tonight, we have four guests. Mindy Rabinowitz is one of our rhinologists. Joseph Spiegel is one of our laryngologists. Elena Toscala is another one of our rhinologists. And we have Julia Croce, one of our audiologists. We're going to explore opening up the office and talk about things that are likely pertinent to all of you in private practice, including the check-in and waiting process, the room turnover, and then special circumstances surrounding audiology and allergy patients. I want to acknowledge this is our fifth one, and I don't think we've properly acknowledged all of the support we get in this. Two people, Michael Packer and Shamval Bilal, have been doing an extraordinary job throughout the COVID response in our department, and we wouldn't be doing these webinars without their technical support. And then we've had multiple residents, namely these two, Mark and Tyler, who have been helping with the data acquisition and putting together some of the slides that you see. As always, I'd like to remind everybody of a few things. This is our department making a presentation. We don't speak on behalf of Jefferson as a whole. We do like to share our practices because we recognize that a lot of you are asking the same questions. I'd like to remind people that most of what's out there and published on COVID doesn't reach evidence above expert opinion. And you can even question the expert part because I'm not sure anybody's a true expert in COVID. This is somewhat new to all of us. I'd like to remind you of the date because if you watch this later, please keep the perspective of when we were talking about what we are presenting. Please mute your phones and microphones, and please use the chat for questions and comments. We are interested in answering questions and try to keep some time at the end. This is our department led by Dr. Keene. We show this just to show the size of the department and remind you that we do have several outpatient offices and we are developing strategies particular to each. This is our word cloud of all the things that come to mind. As I mentioned earlier, tonight's topic will be outpatient care in the new normal. By tradition, we go through some numbers at the beginning and we'd like to look back on where we started. So 6 weeks ago was the first night of the presentation. On that night, there were 70,000 approximately confirmed cases. It later went over 85,000 when the United States became the #1 country in the world with regards to confirmed cases. Strikingly, in retrospect, there were 1,000 deaths on that date. If you look at how we've grown 2 weeks later, I'm going to show you every 2 weeks, there were 449,000 cases in the US, approximately 400,000 more cases, 16,000 deaths, up from 1,000. Globally, there were 1.5 million cases. So that's 4 weeks ago. 2 weeks ago, we've added another 4,000 cases approximately, and more deaths in the United States, 42,000. We added approximately another 1 million global cases, and that trend seems to continue. So the updated numbers for tonight, another approximately 400,000 cases to 1.2 million, and we are now around 75,000 deaths in the United States. We're now 3.7 million and 265,000 deaths globally. So the United States over this past month has certainly taken up their fair share of the global confirmed cases, approximately 40%. We've shown this slide before. This was a White House briefing at the end of March when there was the emphasis of the importance of flattening the curve. And it was discussed that even with flattening the curve, we can expect between 100 and 240,000 deaths. Now, 2 weeks ago, we said we were happy because it seemed like efforts were effective and the expected deaths had decreased with new projections around the 60 to 70,000 range. I just showed you that we already eclipsed that. And earlier this week, it was remodeled to suggest that our estimated death total in the United States through March is back up to 134,000 cases, which is back to that original estimate. We showed the source data of this. So this was 2 weeks ago. This is the IHME data. And at that time, we were talking about, well, we think we're coming down off the curve. And you can see that the peak on April 17th, and it was estimated that 58,000 beds were needed. On May 7th, so today, you notice the curve. When we thought we were coming down 2 weeks ago, wasn't actually coming down. And so our numbers currently are the same, the estimated number of beds now as they were at the that time reported peak. They no longer report the peak, probably because of this bumpy shape to the curve now. If you look at Pennsylvania, you'll also see that the curve took a turn in a direction that we did not expect. We were talking last time that we were coming down a curve, and you can see that not only are we at the same level, we're 20% higher than the previously reported peak today. So even though we're happy that things seem to be coming down, we're not so sure of the pattern we're facing. So headlines, one headline is that elective surgery can resume in Pennsylvania. And I will tell you, at Jefferson, we reopened our surgery center this week. We started to expand our operating room capacity at our main hospital. And so this is happening. But the other headlines remind us of the reality of this, and that is that we are far from back to normal. And this upper headline here shows a Reuters poll that suggests that most Americans, fewer than half, have any plans to go to a sporting event or the movies or a concert anytime before a vaccine is developed. And so we can think about that for elective surgery too, and we're starting to see that as we talk about coming out of the backlog, that when we contact patients, there are plenty who have that same attitude that no thanks, I can continue to wait. The final headline I'm going to show is a graph from the New York Times that is a little bit sobering in terms of where the numbers are across the country. So we're obviously, everybody's happy that the New York metro area is following that almost bell-shaped curve and coming back down, but it is not the same trend nationwide. So our update today, the summary is that things may never go back to normal. And I think that's what we've been saying, and it's become more of a reality. And so instead of saying we may need to create a new normal, I think we all recognize that we will need to create a new normal, and that's got to be okay. So tonight we're gonna talk about that new normal in our outpatient setting. So I'm going to turn over to Dr. Rabinowitz. Is she able to?
Thanks, Dave. I just got word from our IT team that the sharing screen has been disabled. So if you don't mind, I'll ask that you
no problem. I'll try to predict when you're ready to advance.
No, I apologize for all the animations in advance.
No problem.
Thank you for having me tonight. As Dave mentioned, I'll be talking about the waiting room and check-in process during the COVID era. So really for an outline today, it's going to be focusing on really two
Mindy,
main
I'm sorry to interrupt you. See if you can take control of the mouse. I just tried to share it with you.
mouse. Oh yeah, did you do that?
Yep. So go ahead. You have control.
All right, wonderful, thank you. So we're really going to be focusing on two main principles. First being just the waiting room logistics, how you're going to set up your waiting room. And then secondly, to what you can do to ensure safety in the waiting room once patients are there. So the CDC published medical waiting room recommendations, and there's not much in that document. However, there's really two main areas that they focus on. First is to create an area to physically separate patients. And as we all know, we've heard about many times now, we want to try to separate patients to be about 6 feet apart. If the facility lacks a waiting room, then you want to try to create areas with signage that physically separates patients. So that could be out in a courtyard or a hallway, whatever works for your particular building and your practice. And then in terms of the actual waiting room area, we want to try to do whatever we can to reduce crowding in the waiting room, reduce the number of people we have in the waiting room, even while we're trying to ramp back up in patients. So there's several ways to do this. You can ask patients to wait in their vehicles, and their vehicles can serve as your virtual waiting room, if you will. For those patients who take public transportation, they walk, they take Uber, what have you, and they don't have a vehicle to wait in, then you can consider creating outdoor standing or waiting area sections so that they're kind of roped off and not physically clustered together in your waiting room. So how do we go about creating that virtual waiting room? And as we said before, the goal is to try to reduce clustering in the waiting room. And so you want to try to use some other waiting space other than your waiting room. And as we mentioned, that could be patients' cars or outdoor waiting areas, hallways, etc. And so once these patients are not physically in your waiting room, you need to have a way to communicate with them. That can be done with phone calls. Again, depending on the number of patients being seen through your office, that may be doable. However, something that has been shown to be very effective for this can be various kinds of texting platforms. And what's nice about these is that it can be a nice way to communicate with patients that can be automated so that somebody in your front desk staff doesn't have to sit there and make all these phone calls. Many of these different platforms have algorithms to calculate physician wait times so that you don't physically have to have someone there calculating wait times for every physician. And once you designate what your texting timing and platform will be, those texts can be automatically sent to patients to give them instructions on what to do. And I'll give you an example of that in just a moment. In terms of options, there are several. These include programs such as Navimize, OHMD, Google Voice, Doc Clocker. In all fairness, I don't have a lot of experience with all of these. At Jefferson, we are looking into Navimize. Navimize is very nice because it can potentially integrate with your EMR. However, for facilities where that's not an option, they do have a standalone platform which can be used separate from your EMR if you don't have an EMR. So an example of how this may work is, let's say you have a patient who's scheduled to be seen in your office at 1 o'clock. You may set up your texting platform for that patient to get an automatic text about an hour before their appointment, just indicating that when they come to your office, they should wait in the car until they receive further instructions. You then may set up a text for them to get about 15 minutes before their appointment time. If you're running on time, that text may say, we're ready for you, come into our office, you'll be screened when you come in, and you'll be brought directly back into an exam room. What's nice about many of these platforms is, as I said, they have ways to calculate physician wait time. So if you are running 30 minutes behind, that text can say, your physician is running behind, please wait in your car, we'll text you in another 15 minutes giving you updates. So the patient is looped in and has real-time updates throughout, and this can all be done automatically without someone having to physically do it. And then in terms of check-in, ideally in an ideal world, it would be great to have a virtual or remote check-in where you may be able to have your office staff call the patient, get a copay over the phone, or do any other check-in process remotely. Again, that will help to reduce the cluttering and clustering within the physical waiting room. However, we recognize everyone's waiting room is different, and there may be patients that just need to come into the office, come into the waiting room and wait. That may be that they can't be checked in remotely. They need to sign paperwork. They don't have a cell phone. They don't speak English, or you can't have a texting platform set up. And so for those patients who do need to come into the waiting room, we want to make sure that we have a way to ensure safety. And then you can start considering reconfiguring your waiting room to ensure appropriate distancing. Again, there's that 6 feet apart between patients. Our approach is one in which we try to physically separate patients by putting up barriers, and I'll show you a picture of that in a moment. One is you may want to consider instituting plexiglass barriers at the check-in and check-out to protect both your staff and patients. And then in our situation, we're creating X-shaped pods with physical barriers between seats to make sure that we're ensuring social distancing between patients and creating a barrier between them. So what does that look like? This is just a schematic of one of our waiting rooms. And as I mentioned, at our check-in and check-out, we are planning on putting up plexiglass shields. We are going to have a designated cleaning station for some personnel to be designated to be cleaning the waiting room in frequent intervals throughout the day, and I'll talk more about that. We happen to have 2 entrances into our waiting room, and so there will be a screening station situated at each entry point into the waiting room. In terms of where the patients actually sit, we've created little pods, as you can see here. There's physical barriers, which are designated by these red lines. And in each one of those segments, there's 2 chairs so that can hold 2, really 1 patient and maybe a companion if they must have one. And so they're physically separated by a barrier as well as abiding by the 6 feet distance. Just as an example of one of these seating barriers, these are those same things that you may see in cubicles. You can get them in various kinds of sizes and configure them in any way that works for you in your waiting area. Plexiglass barriers, these are pretty standard. You've seen them in many different locations, just a physical barrier to separate the front desk staff from patients. As I mentioned, upon entering into your office building or your actual office waiting area, setting up screening stations is ideal. You can consider actually designating a specific elevator or specific entrance for your patients depending on the configuration of your waiting room. You want to have hand sanitizer available at several different points throughout their visit, particularly when they enter and exit the building. At these screening stations, their temperature will be taken. You want to ask your COVID screening questions again. Fever, have they had COVID contacts, cough, shortness of breath, loss of smell or taste. Ideally, we want to try to limit the number of visitors or companions that patients bring with them. In an ideal world, they wouldn't bring anyone with them. And then everyone really should be wearing a mask. So it's important to recognize that visibility and awareness is really important in the waiting room. While we physically want to create a safe space for patients, the perception of safety is just as important. Reminder notices should be placed throughout the waiting area, just reminding patients to hand sanitize, wear their mask, and also just reminding them what the symptoms to look out for are. It's also important to try to update patients on what to expect when they come to your office in this new normal. Posting on social media or other kinds of communications that you have with patients, just letting them know what to expect can be very helpful. As mentioned, cleaning is really the name of the game here. You want to disinfect frequently. It's ideal, if possible, to assign specific personnel to clean the waiting area throughout the day. If you have an elevator, in addition to frequent cleaning, if you can designate an elevator for your patients, that's ideal. So you can control the cleaning of that elevator. However, that may not be possible, and you can just limit the number of persons in the elevator. And then in the waiting area itself, you want to remove any tabletops or other surfaces that are not necessary so as to limit the number of surfaces that potentially could be contaminated. Ideally, you should have chairs only, no furniture or other decorative items. And patients should be seated immediately and remain in their seats until they're called back. And so I thank you very much for your time and stay safe. Oh, I'm sorry, and then I'll introduce my next speaker, my colleague Joe Spiegel, who will be talking about clinic room management.
I'm trying. All right, so I'm going to switch remote control to you, Joe. And make sure you're unmuted, Joe. Oh. Joe, unmute yourself. I got it. Okay. So I can't find you, Joe. Can you, there we go. You're unmuted.
Okay, can you hear me?
Yep. And you have the, you should have, you have to accept control.
There you go.
Okay.
Okay, sorry for the difficulty. So I was tasked with a team of people that included Gersten Nyquist and our nursing team and IT team to come up with how we're going to handle our individual clinic rooms. So we'll start with just general rules that the patient will be alone when they come to the room. There'll be a couple exceptions of patients who need attendants or translators, but that's the goal, is to have the patient come in alone. Rooms will be designated as aerosol generating procedure, AGP rooms or non-AGP rooms. And some of our most common procedures are potential AGPs. An AGP is a procedure that results in the patient coughing and sneezing and potentially spraying aerosol. So all NPLs, all nasal endoscopies, all endoscopic debridements, all tracheostomy tube changes, and all tracheostomy tube suctioning are potential AGPs. And we'll have signage on the door of every room as a procedure room versus a non-procedure room. The nurse is going to enter the room first and do the workup, leave the room, and then the doctor enters the room alone. When the patient leaves, they leave from the clinic room out of the office without checking out within the office. And we've removed all atomizer sprays from the room, and topical anesthesia, if it's utilized for endoscopy, will be provided on a cotton or cottonoid pledget directly into the nasal passage and then removed. The rooms will be as clear as possible, and all unnecessary supplies will be removed. Gloves and tissue that they used to sit out on the counter or on the walls will be removed and put in the cabinets. Instruments will be placed on the SMR surface by the nurse to be ready for use by the doctor for each visit. PPE, and this is, of course, what we're all thinking about. So first of all, the process, hand hygiene is critical in everything, but it's also critical to understand to do it before, after, and at certain points during PPE use. The patient's going to wear a mask at all times, and anybody the patient brings in the office with them will wear a mask at all times. The nurse wears basic protection of a mask, eye protection, and gloves when going in the room, but will try to avoid patient contact. Physicians will avoid ties, wear a white coat or cloth gown over their clothes or scrubs. A basic exam is the same type of protection, a mask, eye protection, and gloves. A mucosal exam, however, looking in the mouth, looking in the nose, will require an N95 with an over mask. And then an AGP is what we would consider full office PPE, which includes face shield or goggles, as well as your N95 mask with an over mask. Nurses will not be in the room when we do these procedures, but sometimes they will be necessary. As you know, certain tracheotomy patients especially, you need an assistant, and the nurse will wear the same PPE as the physician in those situations. Lastly, we think it's really important that the nurse or medical assistant and the physician act as a team. There's a real process to how you take on and take off the gown, how you wipe down the shield, how you remove it, take off your gloves, wash your hands, put on gloves again, and remove the rest. And having somebody watch you do that, assist you tying the gown, taking off the gown is very important. And you can watch each other and make sure you're doing it correctly and stop and wash your hands again if you've made a mistake. Room cleaning, this is another big point. So this is very similar to what we're already doing. We're going to be careful and use high-level disinfectant, and wipe down all horizontal surfaces, chairs, handles. And then you have to know the drying time of each product you use. The rigid scopes, it's really the same protocol we've been using now, and same with our flexible scopes. And I think everybody's just much more attentive to it and making sure that whoever is doing it is taking their time with each step before the scope is turned over. And this is the last part that we've really had to pay attention to. So in room cleaning between each patient, we've looked into our own SMR units. The filters that are in line with the suction have to be changed on a monthly basis. Like all filters, these are becoming a little bit more difficult to get, so you have to know what your standards are, and there is material for each of these machines. Instruments will be removed in a closed tray, and audiology rooms I'm going to leave up to Dr. Croce to really go through any more details, but basically no unnecessary equipment or materials in the room, and a mask worn by the patient. In terms of how you decide to do room turnover, if there's no AGP in the room, no potential AGP, the cleaning procedure the turnover is based on the drying time of the wipe down of the room, which is about 5 to 10 minutes at most for most of these products. In an AGP room, the rule is, we're going to set the rule at 1 hour from the completion of the AGP until the next patient is brought into the room. That's not 1 hour from when the patient leaves the room, it's from when that AGP event ended. This is based on CDC recommendations that the air exchanges 6 times before a new patient comes in. We are going to add commercial HEPA air filter systems that are small fans that turn over the air through a HEPA air filter into each room. The filters claim they can exchange the entire room within minutes for each exchange in small rooms such as ours. We're using units that are qualified at 200 square feet. But these are not tested. They haven't been tested by the CDC or our own biomed department to see how they're going to affect room air exchange. We think it's going to help our turnover time, and we also think it will be very good PR for the patients to see this in each room. And the last thing we want to cover is communication. And we're used to having a nurse right in the room. We're used to having a scribe in the room, so that the discussion with the patient and the decisions that we make and the documentation of the exam is automatic. And we're working on methods so that basically we're all in conference, listening to each other, even though there might only be one person in the room with the patient at a time. And our IT team is working diligently with different options for this. And I'm hoping by the next webinar, we have some answers for you and we can keep you up with this. And I want to thank everybody and hope everybody keeps safe. And we'll keep lines of communication open as we figure this out. And I want to introduce Dr. Tascala, who's going to talk about allergy as we are in this new age.
Thank you, Joe. And I think, can you move on with my slides? Thank you. So good evening, everybody. Allergy obviously is something that some of you, or maybe most of you do, or at least your colleagues do. So we wanted to touch base on this and what's happening with COVID-19. So when the pandemic started, the first 3 weeks, we just stopped everything. There was no certainty how long this is going to last. And it felt like that doing allergy was not as necessary as some other things that needed to be done, and wanted to also save on PPEs. And then when it looked like that this is going to be a long-term new normal, at week 4, we invited back all our healthy patients, meaning that they had no risk factors to come to office. We had them basically come directly to the allergy room, get their maintenance shot. Most of these patients are in four-week intervals. So for them, this wasn't really interruption of their commitment to the allergy shots. As you know, it is 3 to 5 years commitment to getting your shots. And these were the patients that we felt that they had already significantly committed both their time and resources to get their allergy treated, and wanted to have them as our first group that we started to treat. And those who were in sublingual, either the most of these patients actually are on the drops. And as you know, some patients might have the tablets, but these were the drop patients. We either asked them to pick up from the delivery from the building outside. Actually, one of the patients, one of our nurses lives close, and she just dropped to him the drops. So we tried to keep them on their treatment without actually needing to come to see anybody. With biologicals, as an ENT, the only indicated biological that we use for nasal polyposis is Dupixent. And these patients, as you who use this medication know, that they get the shots sent to their home. They've had a nurse to teach them how to do the shots, and they do it every 2 weeks. So there was no problem with these patients either. All the patients that were in escalation phase, meaning that they haven't received their maintenance, we decided that this is something that can wait. And we haven't invited those patients back yet. We stopped also all the allergy testing and spirometry. So next slide, please. And so now that we are actually starting our clinic next week, have you seen, we have very detailed ways to try to protect our patients. We are going to start the escalating patients, seeing depending how the escalation phase is. We might need to go down on the dose or even in a bottle, but we will get them back for their shots, weekly escalation. Again, avoiding staying in the office, getting directly into the allergy room, have a 30-minute time for them instead of 15 minutes, have 2 rooms, that there's never 2 patients waiting and there's time to wipe up the room. Allergy shots and allergy skin testing are considered as a low-risk procedure. So this is enough to have just the masks and the gloves for the nurse, and obviously the patient will wear the masks. And the allergy skin testing is also started when our clinic opens up. We still want to avoid those patients if we have anyone who might have any risk, and talk with the patient. This is discussion with the patient and discussing what it means if we wait longer. This might mean that you actually have to restart your whole escalating phase, and so that's always individual decision, discussing the risks and the patient and what do they want to do. And obviously all these patients go through the screening as you saw before. Spirometry is a difficult one, and I'm a member of the Quadri AI's committee for both allergy and also for CRS. And there is discussion currently that spirometry is considered high risk. It's similar to doing scoping, and it's recommended to do only on patients that are very much need the testing. And in my practice, my patients' spirometry is a diagnostic testing of lower airway hyperreactivity and asthma, follow up my patients who have asthma, and it's something that we can wait. There is recommendation that if patients have PEF measurements or PEF machine at home, they can do the blowing at home. In the office, again, that would be a risk, but if you do it at home and tell me what's your volume is, then we can discuss about the treatment. So currently, this is going to be something in our setting that we're gonna wait a bit longer before we start. So I think I covered what I had now, and so next I'm going to give it to Dr. Croce.
Thank you, Dr. Toskova, and thank you all for joining us. Perfect. Let's see. Yeah. All right. Oh, we'll go back one. Yeah. Am I able to reverse one screen? I apologize.
Yes.
Oh, you think I can do it maybe at the bottom?
Do you still have control, Julia?
I do, but it seems like the control only takes me forward.
Okay. So let's go there and go ahead.
Perfect. Thank you. So again, my name is Julia, and I wanted to talk to you about how we've been managing the audiology department kind of since this began. So I don't see it moving. I apologize. Perfect. Okay. So
How to take control again. Perfect.
all right. So from the beginning, we sort of decided we're going to, stay positive and focus on the things we can control. And we began by looking at our patient base, so the types of patients that audiology tends to see, converting maximum amounts of audiology patients to telehealth if possible to try to continue our patient workflow. Right away, we agreed that we needed a good tracking system, and this is really department-wide, to track those who could not be converted to telehealth, so we could go back and generate reports and bring these folks in for a later in-office visit. And then we wanted to concentrate on really taking this time and using it as an opportunity to enhance the protocols we have and create new protocols so that when we do come out of this and begin our new normal, we're more efficient and more comprehensive. All of our schedules are always very full for the practice as a whole, and audiology was excited to be able to take some of this time to really make us better audiologists. So we started by looking at the audiology schedules, given that we have audiology services across 6 locations. We have 10 full-time audiologists and part-time audiologists, audiology technicians, insurance verification folks. So we really looked at our team of people, and we decided how we were going to allocate folks between working from home and working in the office in terms of tasks, responsibilities, things like that. So converting audiology appointments to telehealth, those who can be converted were hearing aid and tinnitus evaluations. Interestingly, we've had, I would say I've seen patients that I've seen through telehealth tinnitus evaluations, and tinnitus patients have really been, I would say 95% of them. I still wonder if that's because they're so bothered by their tinnitus that this doesn't stop them, or that maybe stress kind of out the symptoms, right? So it's kind of a cycle, but a lot of tinnitus evaluations during this time. Hearing aid follow-ups, so patients that we had previously fit with hearing aids, we can continue those, and same thing for cochlear implant follow-ups. Some patients just could not be converted. Those are hearing tests. We considered remote testing. The equipment that's out there poses some areas of concern in terms of billing, accuracy, validity, screening versus a full test. So at that time, we decided that we're not going to be able to convert all hearing tests, or we're not going to be able to convert hearing tests, balance tests, or dizziness evaluations, cochlear implant evaluations that require testing in the booth, and cochlear implant follow-ups that need programming or mapping. For those that were able to be converted to telehealth, we use MyChart, Doximity as platforms. Hearing aid manufacturers also have developed individual or manufacturer-specific platforms and mobile applications that we've had to install on our computers, as well as standalone programming on our non-servered computers. For patients, or in addition to the telehealth option for our patients, we've also been offering curbside hearing aid and cochlear implant services that are satellites. Direct shipping between manufacturer and patients. This is something that audiologists have wanted for a long time, and we always sort of had to be the middleman between the manufacturer and the patient. And this has given
All right. I don't know if that's Julia held up or my computer.
I think she's frozen, Dave.
Okay.
Frozen.
So why don't we, we'll see if she can log back in, but why don't we, in the meantime, look to the chat board, because we are starting to get questions on the chat board. And we will open that up. All right. So if anybody has any questions, you can start adding them in. And they can be specific to tonight's presentations, or there's many members of our department who are on as well, who would be happy to answer questions in terms of what you are experiencing in your practices. Of course, if you have any specific advice on something that you have figured out in your practices that you want to share, we're obviously interested in that as well. All right. Why don't we, all right, as we wait for it to see if chats come in, we can pick up where Julia left off. All right, so one question came in is, what recommendations do you have for something as frequent as a tonsillectomy and adenoidectomy? So I'm going to see if one of my colleagues wants to answer that. I know that as we opened up our operating rooms this week, we've had some scheduled.
I mean, I did a tonsillectomy today. I didn't think, as our system, the patient was COVID tested, and I had spoken to the patient a number of times, had been nicely homebound, and then got COVID testing. And, our patients, some patients have fears. Some patients are looking forward to this being a time they can recuperate from surgery without having to go to work. A singer who doesn't have to perform in the near future, it's actually a good time for them to have elective surgery and have time to recuperate. So we had no problem in the operating room today.
Great, and we'll hand this back to Julia to finish up. As we've talked about in previous webinars, we are doing preoperative COVID testing on all patients who go to the operating room. And there are some recommendations for mucosal surgery to use a rinse of betadine or something in the mouth to decrease any potential viral load in the event that the test was a false negative. Julia, I'm going to try to share control with you again. See if that works.
Thank you. I apologize. I lost internet. Alrighty. So are you able to hear me and see me? Or
Yeah.
see the slides? Okay, perfect.
Yes.
Okay. So again, just going back to, in addition to the telehealth services we can provide to hearing aid tinnitus patients, we've also been offering direct-to-ship and curbside hearing aid services and the telephone encounters. For those appointments that could not be converted, for example, hearing tests, I kind of mentioned these issues in the previous slide. As a result of those issues, we're seeing emergent or urgent patients only. So that tends to be, at least up until this point, pre-chemo radiation, sudden hearing losses, fluctuating hearing losses. Otherwise, the patient is rescheduled for a future date, and they are having a telehealth visit with the otologist or the physician in the office for any medical management that can happen sort of outside or until that hearing test is able to be done in the future. Balance tests, vestibular evaluations are currently on hold. We checked in with other academic institutions and hospital settings similar to ours, and everybody seems to be holding off on that due to the proximity of us to the patient, as well as the amount of time we would have to spend with the patient during the test. cochlear implant evaluations that require programming or mapping. The companies like Cochlear and Advanced Bionics are beginning to create remote programming options, but it's not as advanced as it has been for hearing aid manufacturers. So those patients that need programming have been rescheduled, although there are parts of those appointments that can be done using telehealth, and so our cochlear implant audiologists perform or kind of do whatever they can with those appointments via telehealth or telephone until they're able to see the patient for programming in the future. And again, we really emphasize the importance of that cancellation reason being COVID so that we can generate reports and bring these folks back in the future. We, as I mentioned earlier, in addition to kind of managing the schedules and in-office things, we've also really taken the opportunity to look at where we have areas to become better audiologists and patients with more comprehensive care. From the beginning, several audiologists were recruited for other projects on the department, helping with the MyChart support team, which is a group of people tasked with helping patients get through their telehealth visits, both in advance and also the day of the appointment. Some audiologists were asked to reschedule appointments. And then specific to audiology, we do work with Your Hearing Network. They used to be known as AHA. And specifically with their national call center, we use them sort of as a group, as a telemarketing sort of group that reaches out to our patients. Those patients can be patients that have upcoming expiring warranties on their hearing aids. If they came in for a hearing aid evaluation, but they didn't commit to being fit with hearing aids, they didn't come in for their appointment. So we shifted that service from being done by this national call center to our staff doing it ourselves. So that's, that's a way that we've been able to kind of save a little bit there and continue working with our patients for generating revenue even during this downtime. We do use Cycle, which is a hearing aid patient database. We've been using it for many, many years. So we have lots of patients in the database, 5,000 plus. And there's a lot that we can do to optimize it, things that we sort of haven't been able to use in the past. And we're working to clean up the database and being able to use some of the features in it that we haven't used in the past. We also realize that we don't have sort of a spreadsheet or kind of a database of email addresses for our hearing aid patients, specifically within Cycle. So they may have provided MR, we may have their email address listed, but we don't have a way to quickly pull all of our hearing aid or all of our CI patients and send them out an email. And so we're really concentrating our efforts. It's one of the projects we're working on. We've also taken a lot of time to update all of our cochlear implant protocols, our BAHA protocols, and our vestibular protocols. We do offer vestibular testing at 2 of our locations. The equipment is different, so we're really kind of creating protocols and sort of really making sure that it's all organized. And I should mention that a lot of these projects that we're doing are really to enhance current but also future patient care, and of course, a source of revenue as well. Over the counter and big box, for those of you who work with audiology or audiologists, are a big topic right now. So we're creating a starter hearing aid program to keep those patients tethered to us, to avoid them having to go to one of those and stay with us. Our doctoral externs have been off-site since COVID basically began, and we've been able to, despite that, really utilize them and continue their educational experiences even remotely. So they've done some amazing work. They've created a comprehensive cochlear implant manual, a vestibular manual, hearing aid manuals, really some good resources that will be used by audiologists and future students, and just a lot of great work. We've created PowerPoint presentations to help empower our existing patients. We've really started figuring out who needs to come into the office and who doesn't right away. And so a lot of these presentations are going to help educate and empower our existing patients. They can also be used as Zoom sessions for patients who may be interested in technology and who need the educational piece but are not ready to commit and maybe want to learn and hear from other patients. So a lot of patient outreach resources. We're working on an audiology newsletter, which is very exciting. And we've made sure to really continue having huddles and emails and a lot of chat through the Teams platform regarding new ideas, and sort of trying to keep this continued feeling of connectedness, even though we're distant, to truly really make sure that we stay positive and we still continue thinking about kind of how we can become better. Our ramp up plan, currently just kind of on a 2-week rolling basis. We're going to begin seeing patients with the physicians. Our schedules in the first couple of weeks will be built to accommodate hearing test patients only, specifically patients seeing our physician. We're trying to space out our hearing tests with maybe a buffer of some sort in between. We're gathering information as to what is recommended for cleaning of our equipment and our booths. We're talking to the manufacturer about their recommendation to make sure that the venting system is working. There's some information out there. I actually just received, about 2 hours ago that the booth manufacturer sometimes recommend that you wait a certain amount of time, certain amount of minutes, so that the booth can go through a full air exchange cycle. So that's why we're considering a little bit of this buffer, and really just to be able to wipe everything down and wait out the recommended drying time. We are holding off on hearing aid and CI and balance patients at this point. It could change. We're kind of taking it week by week, really mostly so that we can work out the workflow of patients through the office, figure out sort of where the priorities are, volume and our needs. But we do hope to incorporate that. When our audiologists are in the office seeing patients, but the physicians are not seeing patients, or at least not patients for audiology to test, we can use our schedules to continue to do telehealth and to see patients via that avenue. And also everybody sort of staying in contact. So there's a good chunk of time when we can bring in some hearing aid and CI patients. If the availability is there and social distancing rules, we hope to be able to do that, and we can adjust schedules as needed for that, and kind of as the time shows that we're able to do that. We will continue to have some audiologists working from home at least over the next couple of weeks for social distancing reasons and personal needs, and then they will work on those telehealth and the special projects that we discussed earlier. And we can look at considering, hearing aid and cochlear implant schedules on the days that when the physicians aren't there, and maybe we'll alternate an in-office patient visit with a telehealth visit to allow social distancing, but to allow some of these patients to start coming in. So that's really our plan, to continue to kind of abide by all the recommended cleaning procedures, but to start seeing patients and slowly increase that volume. Thank you.
Thank you, Julia. That was fabulous. And I must say, as we've been trying to figure out our processes in our department, there's been an emphasis on teamwork, and our audiology team has been fantastic in the way they've stepped up and supported processes outside of their realm, telemedicine support and other things, as we all work together to figure this out. So I'm going to go back to the questions here. One question is, are there any procedures that you would get COVID testing for prior to a visit? I'm assuming outpatient visit. And that's something that we have not done to date. Part of it is the practicality of it. To get a test, they have to be scheduled for a drive-through, et cetera, and we haven't yet had the volume or performed procedures in the office that to date we feel warranted. As testing becomes more available, point of care testing, we've had discussions about that, and I believe there are circumstances, in fact, I learned of one today, where it will be preferred. I had a call to the office on a patient of mine who's a laryngectomy with the tracheoesophageal prosthesis, having trouble with the prosthesis, who reported that his wife was diagnosed with COVID last week. So we're going to defer that visit, and when it happens, we would arrange and have outpatient COVID testing available to us. There's a question asking, what PPE will we wear for sinus surgery? So as we mentioned before, all patients are tested. As long as they're negative, we're wearing N95s and face shields as standard protection in all of our operating rooms with negative testing. So we do not downgrade the PPE. We're not wearing PAPRs for negative testing. And certainly if one of the rhinologists want to jump in there.
I'll jump in a little, Dave, because I see that Brian asked about doing betadine irrigations, and there's been a lot of stuff in chat boards about irrigating the nose and even the oral cavity with betadine, and we are not doing that. We did do a cadaver study where we made a mask that we hooked up to suction and blew some smoke through the trachea. And really, suction is very effective in really preventing any kind of aerosolization. And there was also just published another cadaver study where they put fluorescein in and used drills and shavers, and there really was no spray outside of the nose if there was a suction in the nose. So our routine is to take a flexible suction catheter, put it along the floor of the nose on the side we're working on, and put that in there.
Great, thanks, Mark. We have a question, what percentage of your usual office schedule are you seeing? And so I can estimate for you, and it's down. So if you look at the past couple of weeks, our average total visits are probably at 40% compared to a similar week year prior. And probably 80 or more % of those visits are telemedicine. So our in-office visits are very small, contracted. All of this that you're seeing tonight is part of our group plan to, quote, open up our offices, and we're beginning to do so this coming week. And we will slowly, incrementally increase the number of patients who come into the office. I think this goes well with one of the other questions, which is, will you continue telemedicine with the office open? And the answer is, until we have this figured out in terms of distancing and flow through the office and minimizing wait, absolutely telemedicine will be a major part of our strategy. And one of the ways that we use it is it helps as a triage tool to figure out who really needs to come into the office. Now, I talked about some of the volume before. That's across the board. If we looked at our divisions individually, there's no question that some divisions are having a more difficult time because the disorders that they treat don't lend well to telemedicine and require more office visits. So we will balance that out as we ramp up the office. The question is, how will you determine which patients are offered telemedicine versus an office visit? Well, they're all offered telemedicine, and that actually helps figure out who comes into the office. But there are certainly patients with technologic problems or obvious medical conditions that would get them straight into the office. Is there a specific goggle that you recommend, something that can be used with glasses? You know, we've talked about the eye protection quite a bit, and you have to ask, is the purpose of the eye protection droplet protection, so truly just a shield, or are we trying to get true aerosol protection of the conjunctiva? And I've referenced before that this is sort of everybody's best guess. I don't think there's evidence, although we can exclude it, that the virus is getting into people and infecting them through aerosol, through the conjunctiva. And I will tell you that for the most part down here, we are not sealing off our eyes. We're using eye shields and other things, or full face shields that protect against droplet. I'm sure they make glasses or goggles, like construction goggles, that seal and fit around glasses. Just pay attention that if you're actually buying them from Home Depot or something, most of those have vents, which wouldn't serve the purpose. Any recommendations for using a headlight while wearing a PAPR? Yeah, that's a big challenge. And yes, you have to rely on overhead lights, and things like that come into issue when you start doing tracheostomies in ICU rooms and portable overhead lights, etc. And do you, the last question here, as we're running just over time, do you have any recommendation for UVC lights? We haven't quite figured that one out yet. It's one of the things that we are actively investigating, and as an institution hoping to get some feedback from the command center, if you will. But we currently are not using lights. You heard earlier that we have purchased HEPA filters as one strategy in our offices. So thank you again, everybody, for logging in. Apologies for the slight technical difficulties and going over a couple minutes. But please know that you can reach out to us all at any time. We recognize that your patients are our patients, and that your communities are really our greater community as well. And so it's in our interest that if we can help you get your offices open and back on your feet, we would love to do that. So please feel free to reach out to any of us for patient-related concerns, or even just the logistics of opening up your offices. Thank you again.